Oriana Dasky, student number 3258349, class is Radiology Spring 2019. For radiation monitoring devices, we use dosimeters made by Mirion Technologies. They work by measuring freed electrons from the scatter radiation after taking pictures of a patient. Values come in and are read monthly, annually, and on a quarterly basis. From the manufacturer, we submit the badges in and get those values back. The radiation monitoring device should be worn for any and all radiographs, including dentistry. And they are worn outside of the personal protective equipment, and the limit for veterinary staff is 5 REMs annually. For the dosimetry reports, we get them monthly after we send in last month's badges. The information included includes the wearer number, the wearer's name, if they're male or female, and what body region the tag is on. So we use whole body tags. And then it gives you a reading for deep, eye, shallow, and neutrophil dose equivalents for monthly, quarterly, and year-to-date. It also gives you the number of reports for that person. So this one is well within the yearly limits for radiation dosage. For personal protective equipment, we have the aprons, and we have the thyroid collar, gloves, and eye protective wear. Each piece is manually inspected before radiographs are taken. Make sure there are no holes, no punctures in the lead that would let a lapse in protection from the radiation. So come on. Our dosimeters on the outside, attaching it to the collar. General safety for radiation includes safely handling your patient. So if you know the patient is aggressive, taking the proper steps to making sure they're as comfortable as possible and your team members are as comfortable and as safe as possible. When doing the radiographs, you want to decrease time, use as low of an MAs as possible, decrease exposure, and use your personal protective equipment and physical barriers. For positioning aids, we have the foam trough to put the patient in. We can use sandbags or we can use gauze to position the patient. 3 types of manual restraint include manually restraining the patient, so physically having you and your fellow technicians holding the patient. Non-manual restraint, so putting the patient in some sort of restraining receptacle and then going behind a barrier and taking the picture. And then finally sedating the patient and putting them in a restraining receptacle and going behind the barrier. Physical barriers you can use for protection would include a lead wall in the radiation suite or going behind another wall or a door out of the radiation room. Distance and time can be used as safety measures. Time, taking the radiographs correctly the first time, using as low MAs as possible with the quickest time possible on the machine itself, and distance, again, staying away from the patient if you can. No portion of any person, shielded or unshielded, should be in the primary beam, indicated by the lighted area here. The primary beam is just a significantly higher intensity of radiation, and the thickness of personal protective equipment is not enough to protect the technician from the radiation beam. Non-essential personnel should exit the radiation room to limit radiation exposure as much as possible. unnecessary radiation exposure. Every effort should be made to take the diagnostic images correctly the first time. This limits unnecessary exposure to the technicians as well as the patient. So check twice and expose once. People under the age of 18 and women that are pregnant should not be exposed to radiation due to the long-term somatic and genetic side effects. Fetuses are most sensitive and at risk to radiation during that first trimester. To get a patient entered into the X-ray system, we log on, it's last name, comma, first name. Oops. The patient's folder number that we have in Avamark. Whether it's male or female, and the patient's birth date. And from there we can select what type of radiograph we'll be doing. So turning on the machine, we're going to come down here, turn it on. We've got our reference chart at the back. So we're going to be lowering the KVP. There we go. Making sure everything is on. All right. Starting with the radius ulna, CRCD, we use her right limb with some gauze. Marker goes at the bottom. We're centering on the midline of her radius ulna, collimating to just proximal of the elbow and distal of the carpus. Shooting. No. Next, doing the VD thorax. 1, 2, 3. Collimating in the center, the midline at the level of the caudal scapula, down to the first lumbar vertebrae and up to the thoracic inlet. Shooting. Taking OFA pictures on the pelvis. Shooting. To retrieve those images that we took, we go to our program and you can search by patient ID, the owner's last name, the patient name, or the day that you took the pictures. So for today, we have, click on today and we can pull up the images that we just took. Or we can search by patient name. And change the dates. And pull up
photographs.
So for my contrast study, I'm taking a barium series on a cat. His name is Watson. He's a little fractious, but he's good. So the normal procedure for doing a barium series is we'll take before pictures, both a VD and a lateral. We'll take pictures immediately after administering the barium, 30 minutes, at an hour, and then at 3 hours. Good job, kitty. Good job. Good job. Oh, goodness. Yeah, he's really
We don't tube cats to give them the barium, we just syringe them in.
Good job, kitty.
Which decreases the risk of getting barium into the chest.
Oh, you got it on your nose. You can stop recording. Taking a right lateral on a barium series. Okay, kitty. Give me that feet. Oh, kitty. Oh, goodness. Oh, goodness. Ready? 1, 2, 3. Shooting.
Hi, I'm Dr. Karen Howe from Minnetonka Animal Hospital. Today I'm assessing Lorianne Nadaski on her radiology techniques and skills that she's learned and improved on while taking radiology courses through her online veterinary technician program. So as an AHA clinic, we really critically assess our radiographic images, and they're evaluated on a quarterly basis for a variety of areas, and the vast majority of them, Lorianne is doing very well. So the areas that we look at are the quality of the image, if there's a complete area of interest, rotation, if there's rotation or rotation motion, missing or wrong left or right image marker, poor quality image, if the area of interest is mislabeled, if there's gloves or hands in the field, and coning. Everybody at our clinic has to work on coning, and so Lorianne fits in just quite well in that area, so she's not alone. Otherwise, all of those other aspects, she has done very well while she's here. She did have her hip dysplasia image, her pelvis image that she took on a dog that was recovering from anesthesia and was already starting to get really tight. She'd had a spay, and so there was she was proceeding with caution to make sure that there was no injury to the dog with her surgery. So that particular dog positioning wasn't ideal, but it was the best that could be done under the circumstances. Some of the things that Lorianne has improved on is knowing why we take various images and sets of images, such as taking 3 views for a chest film is better for finding masses. Doing oblique images are best for finding fractures, and then assessing whether an image is of good quality that it can be accepted versus that it needs to be retaken. She can assess that on her own without having to ask a doctor, do I need to retake this? And she's also gained enough confidence that if she were in a position where she was the lead person taking radiographs, that she could be and have a inexperienced person be her assistant, and the basic radiographs that need to be taken, VDs and laterals and such, and the various extremity positions, that she would be able to take those on her own. And she's continuing to learn, as we all are at the clinic, about how to take bunny skull films for assessing whether or not the rabbit needs to have dental work done. So she is doing a fantastic job, and we're pleased to have her here and pleased to be her mentor. Thank you.